Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am thrilled to have Dr. Hills here with us today. He is with Tucson Orthopedic Institute, and he'll be discussing surgical and non-surgical treatment for hips. You may be watching us today on either our YouTube page or one of our Facebook pages. Please feel free to leave any comments for Dr. Hills, and I'll be sure to ask him afterwards if you've got any questions from his presentation. So welcome, Dr. Hills.
Thank you very much. I appreciate the opportunity. It's great to be with you all today. I wish I could see everybody's faces. The last time I did one of these, we were all face-to-face in a classroom. So hopefully at some point we can kind of get back to doing this again face-to-face. I look forward to that day. So as of late, I've been, well, let me back up just a little bit before I get too far. So again, I'm with the Tucson Orthopedic Institute, and I think it's always important when I have the opportunity to meet with patients face-to-face in the clinic. Oftentimes I get to hear about them more so than they get to hear about me. So I just always like to take just a few minutes to introduce myself a little bit further, if that's okay. So this is a spot not too far from here called Casa Grande Ruins. And this is close to where I grew up, which is in Casa Grande. So I was actually born in Flagstaff, so I am a native to Arizona. But after my medical school training up in Glendale at the Arizona College of Osteopathic Medicine, I entered into the military and went up to Washington State at Brooke Army Medical Center, Madigan Army Medical Center in Tacoma, Washington, which is where I did my residency training. And so it was a great opportunity to live up there. But again, the rain for the majority of the year was incredibly tough to deal with for a native Arizonan. But the Army had it within them to eventually get me back to a desert at some point. And so this is a picture in Afghanistan in front of our field hospital. And so it was just a great opportunity to get out and to serve the country, and especially the brave young men and women who do so much for us in our country. Just as a brief overlook, when we step into that theater, this is what our operating room looked like. And so we essentially had one anesthesiologist, one general surgeon, myself, and then multiple nurses and medics there to assist us in our operations. And so it was just an incredible and very unique learning experience for me. But you learned how to manage, and I think it has prepared me well for dealing with stressful situations in the operating room and in life in general. And as you can imagine, things can get a little bit tough when you're dealing with war injuries. And so it was just a great opportunity to really serve. Notice the smirk on my face there. That was just getting ready to leave Afghanistan and heading back to Landstuhl, Germany, where we were living at the time. After my time in the military, I went to California at the University California, Los Angeles, at the Santa Monica Hospital there for orthopedics to do a little bit more specialized training in how to deal with complex hip and knee reconstruction issues, to include revision surgery, joint infections, etc. And what a great opportunity that was. And so after my completing that extra fellowship training in joint reconstruction, I then finally transitioned back here to Arizona. And so it's nice to be back amongst family and friends. It's been quite interesting as of late to see the amount of patients that have been coming in really discussing a variety of hip conditions, especially over this past year. It seems as though a little bit of the focus has turned away strictly from osteoarthritis into some other aspects of hip pain. And so that's what I was hoping to discuss a little bit with you today, as well as some of the general osteoarthritis that I deal with. And a lot of it seems to really come about by more sedentary lifestyles, as we've been more confined to our homes rather than being out and about and doing some of our normal routines. The thing I think that's most challenging about hip pain is oftentimes it's a little difficult to understand exactly where the source is coming from. You imagine, if we touch the skin, underneath the skin, there are many, many layers until we eventually get down to the hip. And so there's just a lot of different things that could be in play for the cause of hip pain. And in fact, I like this picture because it kind of signifies what some patients show up describing, which is hip pain, but yet they're kind of touching upward towards their backside just a little bit more, right above their gluteal muscles. And this happens quite frequently in that back pain can actually masquerade, if you will, as hip pain. So we kind of refer to it as referred pain, if you will, similar to individuals if they have a heart attack, right? They end up grabbing their left arm, which is where they sense it. And so oftentimes individuals who are describing some upper hip pain towards their backside, it truly is most often coming from their back. But if we focus back down onto the hip, hip pain can refer from the back all the way down the side, but there's also other issues that occur on the side of the hip that can be at play. And in terms of the actual hip arthritis pain, usually that's coming from within the groin, can refer down the front of the thigh, and occasionally down to the knee as well. Most commonly, that type of arthritic pain that we'll discuss shortly tends to really make people's range of motion and things like that much more challenging as well. So if the hip motion is normal, not too painful in the groin, but is more towards the backside, we really should start thinking about lower back pain versus some of these others that we will discuss here shortly. So here's kind of like a view of the hip where we have taken away some of the muscle as well as some of the skin to identify a few common problem areas. And so you'll see on the screen there something referred to as the greater trochanter. That is the side of the hip bone that people feel as you kind of put your hand down the side of your hips. Over that particular region, as it creates this prominence, if you will, there are different bursas, which is a specialized tissue that is designed to allow for some lubrication between the tendons, muscle, as well as the bone. So as you are going through movement, these little sacs of fluid allow the tendons to glide over those bones nice and smoothly. However, unfortunately, they don't always behave, and we can develop irritation within them, and that often can result in inflammation, and that inflammation can become painful, and we've referred to that as bursitis. So that bursa actually has inflammation and can cause a significant amount of pain along the lateral or the outer side of the hip. Most people describe pain with touching the side of the hip as well as difficulty sleeping on their side because of that. Also, prolonged sitting in a chair, for example, can also cause some irritation along this region as well. This is a side view of the hip, indicating some different tendons that can be at play for hip pain. And I think the one that I wanted to point out most is the one that we refer to as the iliotibial band. And you'll see two red dots, one up by the hip and one by the knee. And so those two red dots are connected essentially by the iliotibial band, and there are different muscles that attach onto that region. That iliotibial band is one that rubs right over that prominence of the bone. In addition, we also have the hip muscles that come in and attach to part of that iliotibial band as well as the bone in that region. Those gluteal muscles we refer to as often the rotator cuff of the hip. And so just as people can get shoulder pain, difficulty lifting up their shoulders out to the side, and can get some pinching sensation associated with pain with lifting, similar stuff can happen around the hip joint as well, as those truly act as the rotator cuff. They lift your hip up out to the side. And if you get tendonitis in those areas, it can also refer to that pain on the outer portion. The tendonitis and bursitis, in my mind, kind of coincide one with another. So they are very closely intertwined, and oftentimes we have to focus our treatment specifically towards both of those issues. And most often, I usually start patients off with over-the-counter anti-inflammatory medications, as well as exercise therapy that they can either do at home or as well as with a physical therapist face-to-face in their office, which oftentimes I prefer. And the reason that is because I find the physical therapist is a great teacher. They can spend more hands-on time with you and show you specific exercises and work through them with you to make sure that we're doing the exercises appropriately. And as you learn these exercises, become more familiar with them and how they're to be done, what to do, what not to do, then you can then transition those to a home-based program where you can continue those ideally for potentially ever, right? Because it's just good to keep the hips moving and to keep all of our muscles and tendons well strengthened to help avoid some of these more chronic long-term issues. Which brings up the point that if you are having some of these bursitis-related symptoms or the tendonitis, it usually takes about the same amount of time to get rid of it as the pain has been ongoing. In other words, if you've been dealing with that pain on the side of your hip about 3 months, expect it to truly take about 3 months to get over that. There are some other treatment strategies other than over-the-counter anti-inflammatories, Tylenol, as well as physical therapy. And these include both surgical and non-surgical treatment strategies. Here, this picture is showing somebody who's laying down on their side. And we talked about the bursa, and you can see some of that identified in the picture. And we do have some injection treatments that can be performed directly around the tendon insertions where they attach to the bone, as well as the bursa. And this medication does two things. Again, the steroid medication is a potent anti-inflammatory. And what it does is twofold. One, decreases the amount of inflammation that you have. But number two, it also causes a little bit of atrophy. So it can purposefully use to shrink down the size of the bursa to limit its effect in terms of how swollen and irritated it is. Usually it takes about 3 to 4 days for these medications to fully take their effect in around the hip. Sometimes it can take up to 2 injections to truly get its full effect. And it can shorten, hopefully, the duration of your symptoms. Again, as we use our previous example of 3 months, hopefully shorten it down to closer to 6 weeks, if not make it go away, hopefully a little bit sooner than that. And ultimately, if all those treatment options fail, there are some surgical management strategies. And again, you can see in that small picture of the x-ray going right around that prominence of the bone where you actually remove some of the bursal tissue. Now, it does grow back, so it's not like we're permanently eliminating the bursa, but it helps to remove the areas of inflammation to hopefully to the point where it no longer occurs. In addition, the tendons there, if there are any tears, can be repaired just like a rotator cuff of the shoulder. But again, it's a little bit of a lengthy time of recovery on that. I personally do not perform this particular procedure, and I have a great colleague of mine who's more versed in these scope-based procedures in order to assist with this if ever necessary. But again, this is pretty rare that we ever have to get onto this aggressive of a treatment, which is good for most patients, knowing that they can get better without surgery. A couple notes regarding cartilage. Cartilage, as we kind of transition to talking about osteoarthritis, cartilage is a cushion essentially that allows for a nice smooth gliding surface of our joints. And within the hip, it's essentially a ball and socket joint. So the ball as well as the socket are covered by this specialized tissue. And then again, it's a very smooth area, but it's actually alive. There are cells that are within it. And unfortunately, as we age, so do the cells that are inside of that cartilage. And it gets to the point where they just don't function as well as they normally did. And the composition inside the cartilage can eventually change to the point that it becomes weaker over time. And along with that, some of the actual joint can go through some changes as well, where the fluid within the joint becomes less of a lubricant and more like water, and it doesn't have as much compressive resistive forces along with it. And as you start to combine on that, as the cartilage wears away, it gets thinner and thinner, and the bones get closer and closer together, and that's essentially what we term osteoarthritis. So on the left side of the screen, you'll see more of a healthy joint cartoon compared to an arthritic joint, showing that the bone is now becoming more and more worn out as the cartilage is no longer there, essentially to protect it, to provide for a nice smooth gliding surface. The thing that's interesting about cartilage is it doesn't have nerves. And so as the cartilage wears away, more and more nerve fibers become exposed. And that's why arthritis can become painful, because those nerve endings at the bone are exposed. Plus the inflammation surrounding the arthritis can also be a culprit for increased fluid within the joint. And that increased fluid causes more pain. And so if you move to an extreme range of motion, for example, that increases more pressure inside the joint and can lead to more discomfort. Let's take this picture and turn it into an x-ray, and we can see essentially what arthritis looks like. On the left side is a more normal hip. You can see the ball as it sits within the socket. Might be a little bit hard to notice right away unless you kind of squint and pay close attention to the amount of space that you see between the ball and the socket. On the right side of the screen, you'll see that the space between the ball and the socket is more narrow. The joint is a little bit more white, and you have some areas where it's a little bit more rippled in an effect. And that's where we start to see some bone spurs. In fact, you'll probably notice that the ball on the left side of the screen is actually smaller than the right side. And as the bone becomes more misshaped, you can get these bone spurs, and it almost creates a square peg that's trying to fit into a round hole. And so as we experience this, you can imagine with these bone spurs, it will no longer allow you to bend as much as you once were able. And so if you are having challenges with not being as flexible as you once were, it truly comes down to a mechanical problem where the ball simply will no longer fit inside this confined socket, if you will. And as it won't fit and roll through properly, the bone spurs are then dictating how far your hip will bend, how far it will rotate out, or how far it will rotate in. And of course, when you get to those points where you're pinching essentially the bone up against the bone, that is, of course, where people have some pain. This is going to be flipped again, just another view of, you can see a difference of someone who has more arthritis in their hip, this one on the right side compared to the left side. Again, the joint can become more deformed, and we can actually start to develop what are referred to as bone cysts, which are small pockets of fluid inside the bone. They're not necessarily dangerous. It's not cancerous. It's just one of the reactions that the bone can have as it becomes more and more arthritic. So really, what are the treatment options for arthritis? There are many topical creams that are out there to include capsaicin, and another one that you probably have been seeing some commercials on TV, or even I've heard a number of them on the radio, is Voltaren. This is an anti-inflammatory gel that you can rub on skin. And the thought process is that this will be then absorbed into the body and help with decrease some of the inflammation, specifically the Voltaren gel, which is an anti-inflammatory. However, it's not really recommended for hips just because the hips are so far deep for some individuals. I don't think the medicine will really get down into that area. It seems to work just a little bit better for hands as well as knees, where there's not a lot of fatty tissue around the knee. I've had a number, I didn't put it up on the screen, but I've had a number of people come and ask about CBD oils as well. And the jury is still out. We don't have a lot of science surrounding this and whether or not it truly helps with pain relief or not. There was recently done a study was completed in 2019 out of a hospital group in California, where they looked at people undergoing knee replacement surgery, and they compared how much medicine they required both before and after surgery, and compared them to a group who were also using CBD and or medical marijuana. And they found no difference between the two groups in the amount of narcotic medication that they were using, as well as other modalities such as Tylenol and anti-inflammatories. And so it's really hard to say with certainty whether or not these other formularies or medications or marijuana or CBD are truly that beneficial. So I just exercise caution as you continue to look at some of those other treatment modalities. In terms of oral medications, there's a lot to choose from, and that includes supplements to Tylenol to anti-inflammatories, etc. And we'll kind of go through some of these. I think one of the other main things that I really wanted to focus on was really the holistic kind of approach that we need to focus on. And that is, I see it so frequently, smoking and depression really are tightly interlinked to individuals' pain. And in general, smokers tend to report more pain than the general population that does not smoke. And especially with depression, if it's not treated appropriately, people tend to have more pain. And in fact, many people display their depression as a form of pain. And so oftentimes their arthritis is kind of exacerbated during episodes of depression. And so if there are some challenges with that, eating disturbances, sleeping disturbances, lack of wanting to get out and do certain things that you would otherwise normally be doing, unexplained sadness, crying, etc. Please seek out your primary care physician and discuss some of these different treatment options, especially over this last year, as it's been so stressful not being around and having our normal associations with others. It's been hard on a lot of different people, and so that would be one area to look into as you continue down your pain management journey. So oftentimes I'm asked about glucosamine chondroitin and or joint health supplements. This is another one that's a little bit convoluted. There's multiple studies that have shown that it can be beneficial, but a lot of these have been kind of supported by the companies who are making the supplements themselves, and other large blinded trials where they've compared people and given them placebos to see how they did either with or without it. There really wasn't much difference between the two. And so my best way that I think I can advise you moving forward is give it a try. We know that the medication or the supplements are safe to take for diabetics. Just be close, pay close attention to your blood sugars, as they can elevate them slightly. So you might have to make some adjustments on medications and or insulin. But if you are going to try it, do it at least for 30 days and try it and see how it works out for you. If it doesn't work and you don't notice much of a difference, then I would probably hold off. But if you find that it works for you, it's again a very safe supplement to take, and very rare to have any particular concerns or complications with it, which again are usually mild. So Tylenol is one of those interesting medications that if you ask individuals about how it actually works, they're really not too sure, but they think it just blocks how your brain perceives pain. So it's not an anti-inflammatory. It's not going to help with some of that inflammation that people get around their joints, but oftentimes it's really the only good solution for individuals who have kidney problems and or stomach problems, such as acid reflux, ulcers, and or if you are taking any blood thinners, then the anti-inflammatories really just aren't for you. And so Tylenol is really kind of comes down to the only good option. And so that's very reasonable. We have found, at least within the surgical community, that Tylenol seems to work best when taking it at higher doses. And so at least maybe try the arthritis grade, which is 650 milligrams. And most commonly, if we're doing surgery, we actually give people 1 gram, which is 1,000 milligrams. And we've seen that that's been safe to do if you do it every 8 hours, not going more than 3,000 milligrams per day. Of course, you got to be careful if you drink alcohol regularly, because that requires your liver will be working overtime to deal with that Tylenol as well as the alcohol. And so if you have any liver problems, then be very, very cautious with Tylenol. So in terms of anti-inflammatories, we talked about some of the injectable steroid medications earlier regarding the bursitis discussion. But there are oral steroids that you can take as well, and they can kind of have some of their own side effects. We just got to be a little bit cautious regarding that. And there's also non-steroidal anti-inflammatories, which are referred to as NSAIDs. So regarding the steroids, these are known as prednisone, cortisone, dexamethasone. You've got to be really cautious with these, as long-term use can result in osteoporosis. Some individuals get higher blood pressure, diabetes, there's weight gain, increased vulnerability to infections, thinning skin, more easily bruised, muscle weakness. And there's also another condition referred to as avascular necrosis, and it most commonly occurs in the hip, which is where the bone loses some of its blood flow, and it actually can waste away and die, to where the ball now turns into a flat area. And so, as you can imagine, a flat bone rubbing up against a curved bone just does not work out very well. So we got to be a little bit cautious about, number one, how high the steroid dose is, and as well as how long you're using it. And so that's why most of us usually turn towards the non-steroidal anti-inflammatory medications, such as ibuprofen, naproxen, otherwise known as Aleve, as well as aspirin. There are some prescription grade that we can prescribe to help with as well. And some of those are beneficial because they tend to not work so much on the stomach and increase risk for reflux, as well as ulceration, such as the meloxicam and or the Celebrex. Got to be really careful with these medications, though, because too much of it can be really, really hard on the kidneys, especially during the summer months around here in Arizona, where it gets hot. People tend to get more dehydrated. If you're dehydrated, the kidneys have to work that much harder to get rid of the waste and to keep more normal fluids going throughout your body. And when they have to really crank overtime to filter out all of this stuff, if you add anti-inflammatories on top of that, they clamp down on the important vessels that are within the kidneys. And it doesn't allow the kidneys to filter as properly as they should, and people can have some renal failure from that. So make sure that if you are taking anti-inflammatories, especially during the summer months here in Arizona, that you be sure to take in plenty of fluids. We discussed the topical version of Voltaren, but again, probably not the best for the hip. And I don't even think it recommends it on the box last I checked. So be a little bit more cautious with this one around the hip, unless it's truly something that seems to be more superficial or close to the skin. Otherwise, for arthritis, I don't think it would be a good choice, however. Opioids, I don't recommend any narcotic medications for long-term treatment of arthritis. We've shown that it just increases people's pain paradoxically. Yeah, you heard that right. So the more narcotics you take, the more susceptible you are to pain, and it becomes even more challenging to treat that. And if surgery is ever an option, we've shown that we have to come down off those medications. Otherwise, recovery from surgery is really, really problematic and be very challenging. Injections can also be performed into the hip. We talked about that being done in the bursa and around some of the areas of significant tendonitis, and they can be done in the hip. This is a picture of one going into the knee, which is a little bit easier because it's more close to the skin. But there are techniques and ways where we can actually get the medicine into the hip joint to have a fairly decent effect for individuals. The challenge is this is usually temporary and not long lasting. The duration of which it lasts can vary upon individuals and can be anywhere from a week to 2 weeks, but I've had some individuals that have had good results with it lasting anywhere from 3 to 6 months and sometimes even beyond. We got to be a little bit cautious about how often we use this, because there are some side effects with this as well, to include a steroid flare, to where you can actually have an increase in pain. And there is some concern that with the more of this medication that we use, we can propagate osteoarthritis. And of course, infection is always a risk whenever we poke something through the skin. There's some other treatment modalities which I won't touch on too much, but they're referred to as PRP or Prolotherapy, less commonly done around hip osteoarthritis, but can be good for treatment of tendonitis in certain situations where there could be some partial tearing of that rotator cuff of the hip that we were talking about. There's two different formulations of the PRP, and it really kind of depends if you were trying to either A, decrease the amount of inflammation, or two, trying to actually induce inflammation to induce the body to, or to try to get it to heal itself. And so we just got to be a little bit cautious if depending on which route that we're really going. And we do have a physician here who helps with PRP injections, if that's something that you would be interested in looking at. And his name is Dr. DeWald. Stem cell injections, at this point, I really can't suggest that it's a home run as of yet. Hopefully in the not too distant future, we can understand how to negotiate the stem cells a little bit better to get more long-term treatment. The challenge with osteoarthritis and stem cell treatments, we discussed how the shape of the bone can actually change depending on how bad the arthritis is. And once the bone changes shape, I really think that we have a hard time getting anything to ever return back to quote unquote normal. So I'm still not convinced though that stem cells are the right way to go for hip arthritis and or any of the tendonitis type things that we have discussed thus far. Therapy is important. Getting up and moving, an object that's in motion stays in motion, I think that we've heard. And so if we have arthritis, try to stay away from impact activities. The jarring motion of jogging, running, jumping, and particular Zumba classes, for example, can be a little bit problematic for some of these more arthritic joints. And so try to find something that's going to be less impact. So things like the elliptical, like we're showing here, cycling, pool therapy, where you're swimming and or doing some of these mimicked running and or exercises within the pool are a great way to reduce the amount of stress across the joint by still exercising the muscles as necessary around the hips. Of course, unfortunately, when all else fails, we do have some different surgical treatment strategies to manage the arthritis. And really what it comes down to is replacing the ball and socket of the hip to restore it to a more normal function. Again, we remove the area that is truly arthritic, and with all the bone spurs and the abnormal shape, we get rid of that altogether and essentially replace it with metal, plastic, and oftentimes ceramic to provide a good functioning hip. The surgery itself is usually just a little over an hour long, and the goal is to get people up and walking essentially right away after surgery. And thankfully, this is probably the most successful surgery that we can do as orthopedic surgeon, has been life-changing for many. The rehab is really getting up and walking and strengthening some of the muscles around the hip, but you really don't have to work too hard to regain the motion of the hip, as that simply comes with time and with general use and activities of daily living, such as getting up and out of a chair, etc. There are other techniques other than doing quote unquote a full hip replacement, and this is a comparison of someone who had a hip replacement on the right, which is on the left side of your screen, versus what's called a hip resurfacing on the left side on this patient, or on the right side of your screen. You can see that there's a difference in terms of the metal. The hip resurfacing has fallen a little bit out of favor, but there are some in the country that are still doing it. I'm not aware of any that are here in Tucson, but essentially it's a larger ball that is kind of done where you kind of just get rid of some of the surface, those abnormal areas, and put a cap over the top of it, almost like you're capping a tooth. And for the most part, these work really well. The challenge is these are made up of a metal on top of another metal, and that actually is what makes the articulation. And the metal debris that can come from that, unfortunately, can cause some challenges. And so if you are looking at a hip resurfacing procedure, which is usually reserved for younger patients, in their 30s, 40s, and sometimes in the 50s, make sure that you go to someone who's well versed in this and does this on a regular basis, because it's really, really crucial to make sure that those implants are placed perfectly. If not, then they can fail sooner by leaching too much of these metal ions through the body. It can cause problems with nerves, kidneys, as well as other problems with tendons, etc. So just be a little bit careful. I'm not saying that it's a bad surgery, but I think we just got to be a little bit cautious in making sure that we choose accordingly when we're looking at who a good candidate is for this surgery, if you will. I think the last thing I want to touch on is there's lots of different approaches to the hip. And oftentimes people ask me, are you going from the front? Are you going from the back? Are you going from the side? And what I try to tell people is, if you're going from the front or the back, if you look at the long-term studies, there's actually no difference if you go from the front or the back in terms of the long-term outcome. When you're going in from the front, there has been shown to be potentially a little bit less narcotic use, so a little bit less painful potentially, But within the 2-week range, after the 2-week mark, there's really not much difference. And so what I'm currently using is what's referred to as a mini posterior approach, because I think it still contains less risks compared to some of the approaches where you're going through the front. The one where you're going directly from the side is a little bit challenging, and people can end up with a limp. So that's not one necessarily that is done too often. And another focus of mine that I've really been enjoying lately is utilizing robotic-assisted surgery. As I mentioned earlier, it's really key to make sure that we get these implants positioned perfectly. And when we combine technology as well as the functionality of these hips to making sure that we get the implants positioned just perfectly to where we get the socket just right, there's less wear, less risk for dislocation, and improves the overall longevity of the hip replacements. And if it ever does come to that. So that wraps up what I have for you today. Hopefully you found it somewhat informative regarding some different treatment strategies for hip pain, including the arthritis and other things that might be causing your pain. So again, just try to be aware of where your pain is coming from, whether it's more towards the upper buttock region, more towards the sacrum, or lower back versus the side of your hip and or groin, recognizing that more groin-related pain is usually coming from hip arthritis more so than some of these other modalities or problems that we've discussed.
Thank you so much, Dr. Hills. I had a question about the steroid injections into the bursa. And I think you mentioned that they typically last about maybe 2 weeks at the most, typically?
That was referring to, everybody's a little bit different, but the goal of that medication, again, is to decrease the inflammation and hopefully just nip it in the bud to where it doesn't come back. I have had a few patients, as I discussed. Again, I think it really depends on how long that you've been dealing with the inflammation in the bursa. So oftentimes, if it's been going on for 6 months or close to a year, I think you're going to require at least 2 injections, which I usually place about 3 months apart. I think if you do it too close together, it can be problematic. So the goal of the injection, to get back to your question, hopefully one injection alone will take care of it and it will never come back as long as you continue with the exercises that are taught by the physical therapist. But most commonly, it lasts at least 3 to 6 months.
Okay, great. And then is there anything else that you would recommend that you would have to continue for over a long period of time? Because it sounds like that's really to hopefully take care of the issue once and for all, right? But I guess if it doesn't, is that when you're looking at basically having a total hip replacement?
For arthritis of the hip, yeah, if the pain just continues to recur, what I tell most people is that you'll know when it's time, because you are no longer going out and enjoying the things that you once liked to do, right? And so if you're no longer going out on walks anymore, or taking the dog on a walk, or being able to keep up with family because your pain is now the limiting factor, it's probably time to start thinking about really addressing the hip sooner rather than later, just so you can continue to get on and enjoy life. So if some of these other treatment options just simply aren't working, despite therapy, the anti-inflammatories, plus or minus the injection, if it's not getting better, then it's definitely time, I think, in my opinion, to move more towards a hip replacement.
And the exercises that you had mentioned, are those things that you might want to start earlier in case you're feeling like maybe your hips are starting to wear out? Or
yeah, absolutely. Yeah, and so be honest with you, if you simply get on Google or your browser of choice and put up hip strengthening exercises and just start moving, start working those muscles, start strengthening them, especially the rotator cuff ones where I was talking about moving out to the side. So there are a plethora of different samples that you can find. I would prefer that if you go to any resource about hip pain, go to ones that it could be like reputable sources. For example, Mayo has them. The American Academy of Orthopedic Surgeons has a website that's dedicated to patient exercises. So if you go to those resources, it's probably better than just going to a random page on YouTube, for example. So look at those resources and work on those exercises and be selective. If you find one just doesn't work and it causes more pain, avoid that one and try some of the other ones instead.
Okay. And Dr. Hills, are you doing some telemedicine as well right now with everything that's going on, or do you see patients in person at the office?
Yeah, it's a great question. Right now, we're primarily doing everybody here at the office. I find dealing with hip arthritis and some of these other areas of pain, it really comes down to a physical examination to get an understanding of what patients are going through and to help come to the right diagnosis. And so that's my preference. I have on occasion done some follow-up via telehealth after the first visit, so we don't have to come back face-to-face, but primarily it's in person.
Great. And you're located, you only see patients over at the TMC campus, the Tucson Orthopedic that's located there. Is that
correct?
We
refer to it as the TMC, or sorry, the Tucson Orthopedic East office.
Perfect.
That's
okay.
Correct. It's the one right
and
next
if somebody
to
wants to make an appointment, they can, I've put the number up on the screen here, but it is 520-784-6200. So, please feel free to give that number a call if you'd like an appointment with Dr. Hills. That is all the questions that have come in today. I want to thank you so much for being here. It's an important topic, and hopefully I think you've provided some great solutions for folks to look at when they're evaluating their hip pain. So thank you again for being here. Our next presentation will be next week. We have the Mood-Gut Connection on Wednesday, April 28th at 10 a.m. So please feel free to join us if you are interested in that, and that is part of our mental and emotional health. So thank you all for being here today. And thank you, Dr. Hills.
Thanks.